So, good evening, everyone, and welcome to New Year Cancer Treatment Updates 2024. This event is organized to bring you the latest advancement in oncology with a special focus on lung cancer treatment. Uh, to begin, I invite Dr. Sunil Kumar Gupta, sir, to set the tone with his introduction and context setting. Over to you, sir.
Thank you, Samir. Very, very good evening, dear friends, ladies and gentlemen. If you see, lung cancer is one of the important cancer in our clinical practice, and due to industrialization, due to metro cities, pollution, passive smoking, we have more cases of lung cancer nowadays. And if you see in last 5 years, there are a lot of changes in management of lung cancer. If you retrospectively analyze the 10 years back, the 5-year survival of lung cancer is only 15% with different stages, which increases in 2024 to 25% in overall. But if you see the adenocarcinoma of lung cancer, which is a molecular based, targeted based, treatment, 9 targets we have, and today we have a 5-year survival, which is touching the 32% to 33% 5-year survival. So there are a lot of changes in the cancer management. Today, where we are in 2024, we have a galaxy of consultants and delegates, those who will discuss and listen this newer concept of cancer treatment in lung cancer. Today we have speaker Dr. Jyotika Jain. She is the director of radiation oncology at Super Specialty Hospital Narayana. She will tell us about the current lung cancer management, what physician need to know, because majority of time we pick up the disease in a late stage when we can talk about only the palliative treatment. And if you see, we pick up the cancer in early stage, then we can talk about a curative intent treatment. And lung cancer is a disease where we have a multidisciplinary approach in the form of a surgery, radiation, chemotherapy, targeted therapy, immunotherapy, and TKIs. So Dr. Jyotika will tell us about the important thing, which is a very, very important in clinical practice, current lung cancer management, what physician need to know. Dr. Jyotika Jain, please.
Thank you very much, sir. Thank you, AstraZeneca, for giving me this opportunity. Thank you, Dr. Gupta, for giving me this opportunity for such an informative teaching session. Can you please share the slides?
Yes, ma'am.
Can you make it full screen, please?
It is full screen, I guess.
In my, just a minute, just give me a second.
Sure, ma'am.
Samir, this is for small cell lung cancer.
Just 1 second. Now, can you share the slides, please? Now it is full screen.
Can you see the screen, ma'am?
Just make it first slide.
Ma'am, it is first slide only. Yeah.
Okay. It is not my presentation. It was.
Samir, this is a small cell lung cancer presentation.
So this is not the slides.
Right
This
slide.
overview of lung cancer for physicians' perspective.
Okay, 1 second, ma'am.
No, this is Dr. Bharat slides.
These are second slides. So before that, there was overview of lung cancer, physician's perspective.
1 second, ma'am. Let me check. Sir, Ashish ji is sharing the correct PPT. I guess they have shared this PPT only with me, so they are sharing the correct PPT.
Okay. Yes.
Yes, ma'am. Over to you, ma'am. You can
So, shall we start, sir?
Yes, Jyotika.
Yes. So today we are going to discuss the current lung cancer management, what a physician should know basically. So as we all know, next slide please. Can I make a slide movement from my side? Next slide please. Yes. So as per Globocan 2020, if we see lung cancer is the second most common cancer, and if we see the cause of death, then it is the just slide is not fully covered. I think partially slides are cutting.
Now, just say.
Slides are not fully there. I think I should otherwise. So this is they're partially cutting from the side.
Ma'am, slides are fully visible. I guess there is some problem with the system. You can.
No, full screen is shared and it
Just
is
check
not
it.
coming fully.
Jyotika, full, I think so.
It is visible, sir. Just
Yes,
one.
visible, fully visible. The global picture.
Acha, just a minute, sir. What I will do, I will open in my system also. Okay, so now, so as we all know, it is the second most common cancer in the world, and this is number one cause of cancer-related deaths. Next slide, please. As per data for the India, it is the fourth most common cancer, and it is the fourth leading cause of cancer-related deaths. So most common is breast, head and neck cancers, and cervix, and then this is the fourth most common cancer. Next slide, please. So if we see only very few patients, 14% of the lung cancer patients, they are diagnosed in the early stage. And as compared to other malignancy, like if we see breast, distant metastasis, they are seen in almost 44% of the cases. And in breast, if we see, it is to the tune of 10.3%. So basically, lung cancer, they present mainly in the advanced stages. Next slide, please. So if we see, will an early detection helps improving the lung cancer survival? Yes, it was studied and published in 2016. It was seen that 5-year overall survival outcomes, they decreases with increasing the stage. When it is stage 1, over a 5-year survival is to the tune of 92%. And when we move further along the more advanced stages, in stage 4, it is to the tune of 10%. Next slide, please. So if we see what are the various risk factors, as we all know, smoking is one of the leading cause of lung cancer. It causes about, it has been seen like in 10 out of 9 males, they are smokers, and 8 out of 10 females, they are smokers. And it has been seen that it is not the primary smoking, even second-hand smokers, they also are exposed to smoke, and that leads to more lung cancer. If any family history is there, those patients, first degree relatives, they are having lung cancer, then twice they are more having possibility of developing CA lung. Radiation exposure because of any prior medical history, or asbestos or radon exposure. All these, they are the leading cause for cancer, lung cancer, more chances of lung cancer. Next slide, please. So if we see, initially there are two types. Lung cancer is divided into two types: non-small cell lung cancer and small cell lung cancer. Small cell lung cancer, that constitute around 10 to 15%, and non-small cell cancer constitute around 85%. So major chunk is non-small cell carcinoma. Small cell carcinoma is also called sometimes oat cell cancer, oat cell carcinoma, or small cell undifferentiated carcinoma. Non-small cell is further divided into squamous or non-squamous, and squamous cell carcinoma constitute around 25 to 30%, and non-squamous is further divided into adenocarcinoma, large cell carcinoma, and other subtypes, which constitute adenosquamous and sarcomatite. So major two subtypes in non-small cell carcinoma is squamous cell carcinoma and adenocarcinoma. Adenocarcinoma is the tune of 40%. So all the treatment is decided based on whether the lung cancer is small cell carcinoma or non-small cell lung cancer. Next slide, please. So it was seen that the around 12 to 14% of the lung cancer, they are small cell carcinoma, and overall survival in these patients is very poor. It is less than 1 year. So it is to the tune of 7.2 to 11.4 months. So this data was published by AIIMS Delhi and Adyar Chennai. Next slide, please. So various advances, they are taking place in various treatments. But if we see small cell and non-small cell, lot of advancements they have happened in basically non-small cell carcinoma. In small cell carcinoma, basically we main two drugs is platinum and etoposide based chemotherapy that makes the cornerstone. And along with that, as slowly over a period of time, thoracic radiation came into picture in 1990s, followed by PCI, role of PCI that came after 2000. And then few more small drugs, topotecan, they are there in the picture. And in 2018 and 19, some MABs, monoclonal antibodies, nivolumab, durvalumab, they came into picture. So otherwise, overall prognosis in small cell carcinoma is not very good. In spite of various advancements, it's really poor. Next slide, please. Now coming to non-small cell carcinoma, they account for around 85% of the cases. And it has been seen histologically they are squamous carcinoma or adenocarcinoma, and various targeted agents, they have been studied, and with molecular profiling, we can get various targetable mutations like EGFR, ALK, ROS, RET, MET, HER2. So all these things, targetable mutations, if they are there, molecular, with the help of molecular testing, all the treatment, whole of the treatment depends on these nowadays. Next slide, please. So if we see before the advent of targeted and immunotherapy in 2006 and 9, there were very few drugs, platinum and pamitraxate and bevacizumab. And now after 2011 onwards, when we got various mutations like ALK, EGFR, ROS, with various targetable mutations, we are now having a lot of agents which are really helping us in increasing the overall survival, along with immunotherapy like pembrolizumab and various immune checkpoint inhibitors. Next slide, please. So whenever any treatment is required in any lung cancer, always multidisciplinary team is required. In this, radiation oncologist is not mentioned. I think they should also be there. And pulmonologist, radiologist, pathologist, medicals, and cardiothoracic surgeon, along with physicians, they are required. So they take a combined decision how exactly we proceed further. Next slide, please. So for early stage, if we can see broadly, like if it is stage 1 or 2, when it is limited to the lung and not involving mediastinum, in those cases, and no distant metastasis they are there, grossly we can say it is stage 1, 2. And when mediastinal lymph nodes they are involved, then it is called stage 3. So in early stage lung cancer, our goal is cure. So how exactly we proceed further? Next slide, please. So it is seen the standard of care treatment of resectable non-small cell lung carcinoma is surgery with the curative intent. So any patient with early stage disease, this should be discussed in multidisciplinary tumor board. And if they are found resectable, surgery should be done. If they are borderline resectable, then neoadjuvant chemotherapy plus minus radiation followed by surgery. And if they are unresectable, then we can proceed with other modalities. In early stage disease, earlier molecular testing, EGFR mutations were not routinely performed, but nowadays we do molecular testing for deciding the further adjuvant treatment. Next slide, please. So if we talk about surgical resection, standard treatment is lobectomy, where whole of the lobe is removed. Pneumonectomy, when hilar, proximal tumor and airway, like whole of the lung is removed. When wedge resection is there, wedge resection and segmentectomy, there are other options where a small segment of the lung can be removed, or wedge resection of the tumor can be done. Next slide, please. So if we talk about outcome in the early stage lung cancer, that needs a lot of improvements. If we see surgery is done, and after overall disease recurrence and deaths following surgery and adjuvant chemotherapy remains high across the disease. If we see stage 1B disease, almost 45% patients, they recur at 5 years, stage 2 62%, and stage 3 76%. So large number of patients, they are recurring. So basically we need to add something more to our standard treatment of surgery. Next slide, please. So it was seen that adjuvant osimertinib provides a highly effective and practice-changing treatment for patients with early stage disease where EGFR mutation, as I mentioned earlier, in early stage we were not doing molecular profiling, but it was seen when EGFR mutated patients, they are there, and we add osimertinib in the adjuvant setting after surgical resection, complete tumor resection, there was reduction in the risk of death to the tune of 73 to 77%. So it was a huge number, really good gain with the addition of osimertinib. Next slide, please. Now coming to management of unresectable locally advanced stage disease. When it is unresectable, when nodes they are there, in those cases we standard treatment when mediastinal lymph nodes they are involved, classified as stage 3. In these cases, our standard treatment is chemoradiation. Next slide, please. Next slide, please. This I have already discussed. So now again, when stage 3 disease, the multidisciplinary team determines that is a responsibility, like in that pathologists, radiation oncologists, medical oncologists, surgeons, pulmonologists, all of them, they should be there. And they then definitive treatment in these patients is chemoradiation is standard of care in these patients. It is usually concurrent chemoradiation, but if you feel that patient will not be able to take the two regimens like chemo and radiation combined, then it can be sequential. Next slide, please. So it was seen that the survival rates remains low following chemoradiation in unresectable stage 3 disease. So it was seen that at 1 year, oral survival post CTRT was 34%, 2 years 13, and 3 years 9%. So there is a significant clinical need of improving patient outcome after chemo RT. Next slide, please. Now coming to management of metastatic disease, so majority of the patient, like 7% of the patients, they are diagnosed in stage 4, and the main aim on in these patients with extensive diseases mainly to improve the quality of life, relieve the symptoms, debilitating symptoms, and limit the adverse events in these patients. Next slide, please. So current metastatic non-small cell management in these patients is basically chemotherapy. Historically, there was chemotherapy. Now new targeted therapies, they are there. If EGFR, ALK, ROS, TKI, any of these mutations, they are there. Then TKIs, they are given. And if they are negative, even in those patients, it is not that still there is checkpoint inhibitors, which PDL1, if that is high, then patients can get checkpoint immunotherapy. So it was seen that with the chemotherapy, survival used to be 8 to 12 months. After FLORA trials with addition of TKIs, it is to the tune of 38 months, and with checkpoint inhibitors, it is to the tune of 30 months or so. So it is earlier days, it used to be, oh, poor lung patient, metastatic disease, nothing much can be done. But now we have a lot more to do with the patient. Next slide, please. So what are targeted therapies? So targeted therapies, basically they precisely identify a particular cancer target, they attack and inhibit that target, and they stop cancer cell growth and kill the cell. So how to identify target in the cancer cells? This is done by the molecular testing on the tissue, and sometimes if tissue is not adequate, this can be performed on the blood test. So which are the targets? Which are the target identified in lung cancer? So as I have already informed, various TKI responsive targetable mutations. So it is seen that almost 50% of the lung cancer patients, they have targetable mutation. So even with metastatic or early disease, now the prognosis in non-small cell carcinoma is good. Next slide, please. So now one more important thing is there. So now in TKIs also, there are various generations. Earlier, there was Gefitinib, Erlotinib, second generation Afatinib, and third generation Osimertinib. So the Osimertinib is really, we can say, a wonder drug. Reason being, it is third generation TKI. What is important about that is it can cross the blood-brain barrier. So any patient who are having brain metastasis, they are really helpful. You really feel helpless after any brain metastasis. They have been excised, you have irradiated, they are recurring at the same place. Then it is really helplessness. But if they are patients, they are having mutations, and osimertinib can be given in these patients, and this is really helpful in these patients. Next slide, please. So now coming to immunotherapy in cancer, they enable our own body system to fight against cancer. So basically, next slide, we see like any immune cells, they activate T cells. So how we can understand, like if PDL1 and PD1, they actually cancer cells and tumor cells, they become friends, and you have to break that friendship. They don't, T cells don't kill cancer cells. If you give PDL1 or PD1 inhibitors, then they understand they are not our friends, they are our enemy. So they start killing the tumor. So this is the mechanism of action of PD-L1 or PD-1, where they make T cells, our own immune system, make them active to fight against the cancer. Next slide, please. So there are a lot of advancements in non-small cell lung cancer with no driver mutations, where immunotherapy that really helps. If PDL is more than 50%, pembrolizumab with combination or atezolizumab, that is helpful. When it is less, PDL1 is 1 to 49. Even in those patients, that is helpful with the combination with various chemotherapy. Next slide, please. So to summarize, I'll say overall the 5-year survival in non-small cell cancer is between 10 to 15%, primarily because majority of the patient present with either locally advanced or distant metastasis. Fewer are diagnosed in early stage, and it has been seen that 30 to 60% of the patients, they undergo surgery, eventually develop metastasis, and there is need to improve further neoadjuvant or adjuvant treatment in these patients. Adjuvant osimertinib will provide a highly effective and practice-changing treatment for patients with the early stage as well as in advanced stages. So, how largest unmet need in lung cancer, this can be recognized as follows, like improving lung cancer literacy and awareness, increasing access to more innovative medication, and in evolving how to think about the patient support to reflect increased survivorship in lung cancer. And fourth is enabling early diagnosis of lung cancer. So currently majority of the diagnosis, they are in advanced stages, and by implementing screening or having strong primary referrals, so this will really help. As we have already seen, if early patients they are detected, the prognosis will be really good. Next slide, please. So we really have to work with partnership with our physician, to whom patient is basically seen by them. Any lung mass, suspicious lung mass is there, they should be promptly reviewed and referred. High index of suspicion, early and prompt diagnosis, that will be key to success. Optimal referral to oncologist or pulmonologist, that is required. And briefing the patient about the importance of various tests. Sometimes patients feel a lot of tests are being done once referred. So if our physician colleagues, they advise patients like it is required, and that is really going to help them in future, they really take it easily, and taking care during complications and follow up and recurrence, they are important with your help. Next slide, please. Thank you.
Medically not
Sir,
fit.
you were not
Would you like
audible, sir. Can you repeat, please? You were not audible, please.
hello? Thank you, Dr. Jyotika, for such an excellent talk. Dr. Bharat Dua is having some medical problem. I request you to please take the presentation of Dr. Bharat Dua. He will basically he will talk on overview of the lung cancer. This is my humble request that you please discuss this topic with the audience and the experts.
Okay, sir. Thank
Dr.
you very much.
Jyotika Jain, I will inform you to all of you that Dr. Jyotika Jain is the Director of Radiation Oncology at Super Specialty Hospital Narayana at Gurgaon, and she will tell us about the overview of the lung cancer.
Thank you very much, sir. So today again, this was earlier it was for physicians, and now we are going to discuss about overview of lung cancer. This slide I have already discussed. This is the lung cancer is one of the leading cause of death, and it is fourth in the mortality leading to deaths in India. Next slide, please. So this is the fourth leading cause of death in India after breast, lip, oral cavity, and cervical cancer. Next slide, please. So if we see the optimum staging, any treatment in the lung cancer requires optimum staging. So there are few changes in AJCC 7th and 8th edition, where size of the tumor from 5 to 7 centimeter, it was earlier 2B disease, now it has been shifted to T3. And T4 lesion, which is more than 7 centimeters, this has been categorized as 3A. Next slide, please. So now coming to the investigation, in what all tools are required for staging a lung cancer. It is not that easy. First of all, bronchoscopy, CT scan. Initially, CT scan is done, which shows some mass, and after that, bronchoscopy is done. We require PET CT, which tells us about the exact extent of disease. We require EBUS, EUS, mediastinoscopy, and MRI for optimum staging. Next slide, please. Now coming to CT versus PET, if we see CT scan, if any lymph node which is more than 10 millimeter along short axis, that is a predictor of malignancy. But if CT alone, if we see, it is having low sensitivity up to the tune of 55%, and specificity is 81%. But if we add PET CT, PET along with CT, then its overall sensitivity increases to 80 to 90%, and specificity increases to 85 to 95%. Next slide, please. So what are the risk factors for occult N2? As we know, staging is very important, because if it is N2 makes a lot of difference, because as soon as it comes N2, then the surgery is out and the other modalities, they are there. So any tumor which is having high risk of occult nodal disease, in those cases we have to see, evaluate the nodal disease. So in which patients we will go ahead with some imaging, risk of occult nodal disease is there. If any central tumor is there, if size of the tumor is more than 3 centimeter, and if SUV on the PET is high, more than 4, then all these leads to more risk factors of N2 disease. Next slide, please. So mediastinal staging, that is very important. We use less invasive EUS and EBUS first, and if required, sometimes mediastinoscopy, which is invasive, that is required. Next slide, please. So initially we recommend EBUS or EUS, which is just ultrasound or endobronchial ultrasound, and you evaluate various nodes. But if clinical suspicion of N2 involvement remains high, even after negative EUS and EBUS, then we require mediastinoscopy. Next slide, please. So when do we do invasive mediastinal staging? When the centrally located tumor, yes, tumor is more than 3 centimeters. If extensive infiltration of the mediastinum with no evidence of extrathoracic disease or N1 disease, in these cases we require mediastinoscopy. If bulky N2 on CT is there, there is no need. But if discrete N2 is there, yes, regardless of PET CT, we require mediastinal staging. Normal mediastinum on CT, but positive on PET, we require that. And if negative on PET, then we can omit that. Next slide, please. So this is the algorithm which we are discussing. Basically, mediastinal lymph node staging is very important. Next slide. So various procedures, they cover various stations of lymph nodes. So we have to see which all we are suspecting after CT or PET CT, and accordingly we use various combination: EUS, TBNA, EUS, FNA, cervical mediastinoscopy, VATS, whatever is required depending upon suspicious lymph nodes. Next slide, please. So non-invasive and invasive techniques, they are required. So you make a combination of that to get the maximum information, and once you are satisfied, you either take CT, PET, EBUS, EUS, and then you stage mediastinum, which is very important. Next slide, please. So now there is evolution of therapy in lung cancer. Non-small cell carcinoma once used to be considered as like two things, they were there: non-small cell and small cell carcinoma. Later on, there were sub-classifications like squamous cell, non-squamous cell, large cell adenocarcinoma. Then thereafter came molecular pathology like EGFR, ALK, ROS mutated. And if they were negative, then PDL1 and tumor mutation burden, they came into picture. And whole therapy of lung cancer, there is a huge evolution in this period. Next slide, please. So it was seen that as advances in the management of small cell lung cancer, they have improved survival. This was an article published in NEJM in 2020, where they have shown that after 2014, when we had various FDA approvals for targeted agents. After that, there was reduction in the mortality, then improvement in overall survival. Basically, this was because of more advancement in the treatment, particularly approval of targeted therapies. Next slide, please. So we can see advances in the treatments. This slide we have already discussed in the previous presentation. A significant increase in approval of both targeted as well as immunotherapy in non-small cell cancer can be seen. We can have ALK, EGFR inhibitors, and like crizotinib, erlotinib, geftinib, whole dabrafenib, and in immunotherapy we have pembrolizumab and atezolizumab, ipilimumab. Various drugs now they are approved and they are showing wonderful results in non-small cell carcinoma. Next slide, please. Next slide, please. So now there is an increasing need for molecular testing in non-small cell carcinoma. Now molecular testing is a standard of care. Like in all patients, we go at least minimum EGFR, ALK, CROS, BRAF, and TRK, MET, RET. These mutations, they are standard and we get treatment modified accordingly. All patients of non-small cell carcinoma should undergo molecular profiling to identify targetable alterations. Next slide, please. Next slide, please. Now, the current guidelines are there on neoadjuvant and adjuvant chemotherapy that depends on the disease stage and finding during surgery. So it was seen that in stage 1A, there is no proven benefit of adjuvant chemotherapy, but 1B onwards, 1B plus minus, and more than that, there was a role of adjuvant chemotherapy. And in histopathology, if any of the N2 nodes are there or positive resected margins, then there was role of chemotherapy. Next slide, please. So as we know, findings at the surgery and surgical resected margins, they affect the adjuvant treatment. If it is early stage 1 or 2A disease, then observation. But if anything more than like 1B, that is where adjuvant chemotherapy comes into picture. But if any of the resected margins, they are positive or R1, R2 resection is there or N2 node is there, then addition of chemotherapy with radiation is done in these patients. Next slide, please. So it was seen that after initial treatment, more than half of the patients with resectable non-small cell cancer, they experienced recurrence. So it was not enough. Surgery was not enough. Surgery as well as chemotherapy, both they were given. And in spite of that, almost 50 to 60% patients, they were recurring. So overall outcome still needs to be improved for patients with resectable non-small cell carcinoma. Next slide, please. So it was seen in ESMO's latest ESMO guideline that in tumors more than 4 centimeter, if any adjuvant chemoimmunotherapy was given, there was an overall survival benefit in these patients. Next slide, please. So then there came LACE meta-analysis in which it was seen that it was a pooled analysis of 5 trials evaluating 4,000 plus patients in which cisplatin and vinorelbine was used, and it was seen that chemotherapy leads to improvement in overall survival. The benefit was to the tune of almost 4% and 5.4% and 3 and 5 years respectively. So post-operatively, if we are adding chemo, there was some benefit. Next slide, please. So how well does neoadjuvant chemo works? Was it same as adjuvant? Yes, it was seen that adjuvant and neoadjuvant chemotherapy both were acting similarly. But if surgically operable patient is there, we go ahead with surgery. But if it is borderline operable, in those cases, we can go ahead with neoadjuvant chemotherapy. Next slide, please. Now, so it was seen that it is also possible, it was seen that patients with completely resected patients, if they are EGFR positive, in these patients, if we are giving osimertinib, then it was seen that there was reduction in the risk of disease recurrence to the tune of 80%, recurrence and death with osimertinib. So it was ADAURA trial where targeted therapy is now moving in the early stage. In this, there was improved disease-free survival with the addition of osimertinib in resected EGFR mutated non-small cell carcinoma. So now it is possible to further improve the survival in completely resected EGFR positive patients where we can add targeted agents. Next slide, please. Now coming to the atezolizumab, again, it has shown an improvement in disease-free survival as well as overall survival in the adjuvant setting. So it has shown when PDL1 is positive by more than 1%, it has shown improvement in survival in the adjuvant setting in patients. And such therapy will have an improved survival rates in non-small cell lung cancer. Next slide, please. Now coming to lung cancer radiation, there are various techniques, advanced techniques, they are there, which are leading to safer treatment delivery. In earlier days, there used to be parallel opposed field, where a lot of normal structures, they used to get irradiated. Now with the help of intensity modulated therapy, where all beams, their intensity is modulated and you can shape the beam. So it improves survival in the patients with stage 3 and T3, T3, T4 tumors. It reduces the dose to the heart and lungs, and which decreases the risk of pneumonia and cardiac toxicity. Next slide, please. So, but now there is another technique which is called stereotactic body radiotherapy, where you give very high dose of radiation in very few number of fractions like 1 to 5, and where you just target the tumor with very minimal margin along with motion management, so that you save rest of the normal structures, and adjoining very high dose is delivered. This is usually done in early stage lung cancer where tumor is less than 5 centimeter. Although fractionated stereotactic radiotherapy can be done in bigger lesions also. Next slide, please. So in lung cancer radiation, we are having newer things like 4D motion management, where 4D CT scan is taken and you treat the patient in particular phase of CT, like or deep inspiration breath hold technique, where patient takes in particular phase of breathing, you treat, so that you need to give very, very minimal margins and you can treat the patients. There is an adaptive radiation also, where when tumor shrinks, you again replan the patient with less margins. And so the very less dose goes to the normal tissues and very high dose can be delivered. So toxicities of heart, esophagus, lung, they can be minimized with newer techniques of radiation. Next slide, please. So now there was another trial in which for advanced stage non-small cell lung cancer, the results, they were not very good. So what they do, they studied whether the dose escalation of radiation, will that help? So they studied two groups, 60 gray and 74 gray. And in one group, they added cetuximab. So it was seen that escalation of the dose is not leading to any benefit, and even addition of cetuximab is not leading to any improvement. Next slide, please. So chemotherapy with or without radiotherapy is the standard of care after complete resection of patients with stage 3 lung cancer. So it was seen after chemo or radiotherapy. Is it still results? They were not very good, and it was seen like multidisciplinary team is required even for them. And it was seen if any N2 disease there or positive margins. This is the radical patient. So N2 disease or like early stage disease, only observation. This we have already discussed earlier. Node positive chemotherapy, 1B onwards chemotherapy, and in stage 3A, 3B chemotherapy or chemoradiotherapy in N2 disease or positive margin. Next slide, please. So it was seen that in early stage disease, unresectable stage, checkpoint inhibitors, they are moving to early stage, and now unresectable stage 3 disease, where it was seen that after CTRT, if we are adding there was Pacific trial, which was a randomized, double-blind, placebo-controlled trial, phase 3 trials of consolidation with durvalumab in unresectable non-small cell carcinoma. So it was seen that durvalumab demonstrated 42.9% overall survival at 5 years, and in comparison to the historical trial where CTRT leads to 15 to 25%. So there was really OS benefit in patients who received adjuvant durvalumab in locally advanced lung cancer post chemoradiation. Next slide, please. Now coming to emerging treatment paradigm in non-small cell carcinoma, we know there are targeted agents, there is immunotherapy. Next slide, please. So we know there are targeted therapies and immunotherapies. Next slide, please. So there are genetic. So now emerging molecular targets, they are there in the non-small cell lung cancer, like if various mutations as already discussed. So newer targeted agents, they are being identified. This will help increase the survival in these subsets of patients with various genetic alterations. Next slide, please. So we have already seen that survival outcomes before. Historically, it used to be 4 months with platinum, 8 months, 6 months, and after addition of EGFR, ALK, RET-MET, various targeted therapies, we can see it is to the tune of 39 months, 24 months. So with the recent advances, survival rates are improving compared to chemotherapy alone. Next slide, please. And next is immune checkpoint inhibitors. In this, we are using body's own immune cells to fight against cancer, and that is helping in with various PD-1, PD-L1 inhibitors and CTLA-B blockers. Next slide, please. So now there is approval of immune checkpoint inhibitors. We can see from 2015 to 2021, various drugs, they are improved: pembrolizumab, atezolizumab, durvalumab, like various drugs. Now we have nivolumab, so which can be used for various patients. Next slide, please. Now, if we see those patients who are not having any molecular mutations, in those patients also we can have really good results with immune checkpoint inhibitors. We can see with the PDL1 positive, any PDL1 positive, even in these patients we can have 22 months, 19 months, 19 months. So nowadays it is not that lung cancer patient will pass in 6 months. No, we have whole baggage of medication by which patient can be looked after. Next slide, please. So it was seen that with the checkpoint inhibitors, we have improved survival in advanced non-small cell lung cancer. Next slide. Keynote 24 trial that showed that the improved survival in the patients with pembrolizumab compared to chemotherapy with PDL1 positive patients. Almost 32% patients, they are alive at 5 years with immunotherapy in metastatic non-small cell cancer. Next slide, please. So it was seen that checkpoint inhibitors, they are moving in the early stage in resectable non-small cell as adjuvant and neoadjuvant therapy, and multiple ongoing trials, they are going on with various other immune checkpoint inhibitors. Next slide, please. So what is new now? Coming to antibody drug conjugates. This is there in breast, which is showing really good results. Now these antibody drug conjugates, they are coming up in non-small cell carcinoma also. Next slide, please. So what is CAR T cell therapy, in which our own T cells, they are genetically modified and reinfused inside the patient to become more effective and fight against cancer. So this is a perhaps in future this will be really helpful for most of the patients. Next slide, please. So the management landscape is fast changing in non-small cell carcinoma. Newer therapies, they have huge potential in improving the survival, especially when detected in early stage. Overall survival is improving across various subtypes with molecular alterations. And treatment is easy oral pill over infusion in case of targeted drugs is really an added advantage. Pulmonologists will play a huge role in the early diagnosis. Hence, it is crucial to involve them in non-small cell lung cancer tumor boards. Next slide. Thank you. Thank you very much.
Thank you, Dr. Jyotika. Now I would like to call Dr. Amit Badola, and he will tell us about the advances in EGFR mutation, non-small cell lung cancer, evidence-based review of targeted therapies, where we are in 2024. Dr. Jyotika Jain clearly mentioned about that there is a role of TKI, first generation, second generation, third generation, checkpoint inhibitor. Dr. Amit Badola is an associate consultant at BL Kapoor Max Super Specialty Hospital, Delhi. Dr. Amit, please.
Thank you, sir. I think my slides are visible.
Yes, Amit.
So my topic is advanced EGFR mutation non-small cell lung cancer treatment and the review of targeted therapy. It's already discussed the epidemiology of lung cancer, and we all know that it's a second most common cancer worldwide, and it's a most common cancer in terms of mortality. If we talk about the Indian data, it's the first leading cause of cancer-related death in India. This is important. The relative survival of the lung cancer, as we know that when the stage advances, the survival is less compared to the early stage. The 5-year survival rate is for the stage 1, it's approximately more than 80%, but it came down to 13 to 30% for the advanced stage. And the hard part is that we diagnose majority of the patient in the advanced stage. As you can see on the left side of the slide, stage 3 and stage 4, they constitute around 80 to 90% of the patient who was diagnosed with the lung cancer. So now with emerging biomarkers, there are more than 50% of the stage 4 lung cancer for which we have targetable therapies. There are only 36% patients of the lung cancer who does not show any biomarkers. Otherwise, majority of the patient, they have either PD-L1 expression or driver mutation in the form of EGFR, ALK, ROS, and other some rare mutations like HER2 mutation or RET mutation. So some of these are having a prognostic and some have a predictive value. This is the testing methodology, but I think majority of the center is now doing NGS. But if we have a financial constraint, we can do a separate all these mutation. We know that for the EGFR, we have a PCR. For the ALK and the ROS, IHC, and we can do also on the FISH. For ROS, actually, IHC is only a screening test. We have to confirm it by FISH. And for now, PD-L1 is only can be done on IHC. It cannot be done on NGS. If we talk about particular EGFR, the most common mutations are seen in exon 18, 19, 20, and 21. And out of these 4 mutations, exon 19 and 21 constitute around 80 to 90% of the patient. And 19 and 21 is the only mutation which are target this TKI sensitive. So if you see this, the overall estimation of the prevalence of EGFR is more common in Asian. It's around 30 to 40%, while in Western or Caucasian, it's only 10 to 20%. And the stage-wide distribution of EGFR is almost similar. So the mutation either in the stage 1 or stage 4, it's almost similar. And now NCCN recommends EGFR testing in early stage lung cancer also. Initially, it was only in the stage 4, but now we see with the data of ADAURA trial, NCCN recommends not only the EGFR, but also PD-L1 ALK in the early stage lung cancer. So basically, if we see EGFR, if it is wild type, it needs a EGF growth factor, which lead to dimerization of this EGFR receptor. and which give the signal for the cell proliferation and protein synthesis. When it is mutated, it's automatically dimerized and give it continuously on this pathway, and the cell start proliferating. This is a treatment option for the advanced lung cancer. I'm sorry, this slide is not that updated, but we basically divide these tumor either driver mutation positive or negative. And now in driver mutation, we have, apart from EGFR, ALK, ROS, we have RET, we have BRAF, V600E, we have HER2, we have MET. We have lots of mutation for which we have oral TKI available, which having a very good response rate as well as PFS and OS advantage as well. If we talk about osimertinib, which is a third generation TKI, it's a beautiful drug. We now very much familiar with osimertinib, and we know that it crosses the blood-brain barrier, which is another advantage of using osimertinib. Another beauty of this drug is that it acts on T790M mutation, which is the almost 50% of the patient. The cause of progression on first generation TKI is this mutation. And fortunately, this osimertinib works in this resistant mutation as well. FLAURA, it's now not the latest one. It's the well-established role of osimertinib is because of this FLAURA, where we have a randomized patient on advanced non-small cell lung cancer who are having exon 19 deletion or exon 21 L858R mutation to either osimertinib or first generation TKI. And the point to be noted here, the crossover was allowed in this trial as well. They included all Asian and non-Asian population in this trial. So if we see the both arm was well balanced, and they have included the patient who were having a baseline brain metastasis, approximately 20% patient, 1/5 of the patient were having either brain disease. And this is the PFS Kaplan-Meier, which is clearly showing that there's advantage of osimertinib compared to the standard of care, having a very beautiful hazard ratio of 0.46. That means there's a risk of progression or death is decreased by 54% in osimertinib arm compared to the first generation of TKI. And the benefit was seen in across subgroups, whether the CNS baseline metastasis was present or not, whether the patient was having a male or female, Asian, non-Asian, in all subgroup, the benefit was there. And when this data matured and it converted into the overall survival benefit as well, where the osimertinib, the median OS was 38.6 months, while for the first generation, it was around 31 months. If we talk about the adverse event, there are very less grade 3 adverse event with osimertinib. It's actually a very well-tolerated drug. And the common side effects are diarrhea, skin rashes, nail effects, which is, if we'll see, slightly less compared to the first and second generation TKI. Even the drug discontinuation rate was also very less in osimertinib compared to the second generation TKI. So in summary, we all know that it's a highly osimertinib resulted in not only the PFS benefit, but also in overall survival benefit. There is a significant and clinically meaningful improvement in CNS PFS compared to the standard of care. And as I told, it's also converted into the benefit in the overall survival. As I was talking about that, the osimertinib can cross the blood-brain barrier. So in the following slide, I would like to see how much benefit of adding osimertinib to the earlier. This slide is showing that there's slight higher incidence of CNS metastasis in EGFR mutation population compared to wild-type EGFR. It's around, at the time of diagnosis, 19 to 24% patient present with a brain metastasis, while with the wild EGFR, it's below 13%. This is showing the PFS, CNS PFS of osimertinib, the patient who is having baseline CNS metastasis and without CNS metastasis. We know that if there's a brain, the disease in the brain, it is having a poor prognostic feature. So that's why the patient who is having a disease in the CNS brain, their PFS is around 15 months compared to the patient who does not have disease in the brain. And for that, it is 19 months. But in both subgroup, the osimertinib is showing a meaningful benefit in the PFS. This is the same slide. If we compare with the osimertinib with the second generation TKI, this Archer 1050 is a trial of dacomitinib with the first generation TKI. And we see the graph in FLORA, the graph started separating early. That means the response rate is better, and it is and we are losing almost 25% in the first 1 year, while if in FLORA, it's the graph started separating very early. For the PFS is around 14 months for dacomitinib, while for OCA it is almost 19 months. And Archer also did not show any statistical significance if we compare, and neither this trial was designed to show that. And while in FLORA, it was the first time when any TKI showed OS benefit compared to any other TKI, either first generation. If you compare with the afatinib is having a slightly less PFS. It's only 11 months, while we saw in with osimertinib, it was around 19 months. And it didn't show any OS advantage compared to the first generation TKI. And if we, this was, I was talking about the safety profile. If you compare with the afatinib or dacomitinib, osimertinib is very well tolerated drug. And if we see the dose reduction was done only in the 6% of the patient, was well compared with the dacomitinib, where we have to do it for the approximately every other patient. It's 66%, and same with the afatinib. So osimertinib is very well tolerated drug. This is another beauty of this FLORA trial. It's not only the upfront comparison of the standard of care, but it is also showing the sequential use of osimertinib in the patient where we were using first generation of TKI. Almost 47% patient did receive osimertinib in the in comparator arm. So despite that, there is a overall survival advantage. So, so the dilemma of sequencing is also resolved by the FLORA. This is important because when we start the patient with the first generation TKI, only approximately 75% of the patient received the second line treatment. We lost around 1/4 of the patient. 30% patient did not receive any second line of treatment. That's why it's important to start with a drug which is having a greater benefit as early as possible. This is showing the same thing, like 30% of the patient in FLORA, in competitor arm, they did not receive any second line of treatment, while 47% of the patient received the osimertinib in competitor arm. This is the real world data showing the same thing, that only 1/3 of the patient is receiving the second line therapy if we start with the first generation TKI. So that's why it's really important to start with a drug which is having a better efficiency and giving you an overall survival advantage. So and it is reflecting in our NCCN, ESMO, and everywhere. Osimertinib is the choice of drug for exon 19 and 21 mutation. And now the FLORA-2 is also coming up, which is showing a better PFS with osimertinib with adding chemotherapy with it. So conclusion, we know that it is the first TKI which translated into the PFS into the overall survival benefit. We have seen first time when only a TKI is giving a PFS of around 19 months, where we know that with the second generation, it was around 14 months. And with the first generation, it was around 10 to 11 months. and having a very good median OS of 38.6 months. And when we are adding chemotherapy with osimertinib in FLAURA2, the PFS is approximately 29 months. Another advantage of osimertinib, as I discussed, it is having CNS penetration and it reduces the CNS events. And there it's very well tolerated drug, so we know that it's a worldwide well accepted standard of care therapy for the EGFR mutation lung cancer patients. Thank you.
Thank you, Dr. Amit, for such a nice talk. I would like to discuss in my talk, basically, this is a refreshing talk. Ashish, could you share my presentation?
Yes, sir, I am sharing, sir.
So after 3 talks, I would like to refresh the things. Basically, this is a clubbing of all these slides. Basically, my talk is focused on the early stage lung cancer. Once we are talking about lung cancer, I always believe that this is a disease where we need a multidisciplinary approach in the form of surgery in early stage, when we can talk about a surgical event. And surgical event means curative intent treatment in up to stage 3A. But once there is a stage 3B, I always believe that I should share my concern with Dr. Jyotika Jain and we should go for a CT-RT. But once there is a disease which is advanced, we always go for a palliative chemotherapy, targeted therapy, immunotherapy. But my talk is basically focused on early stage lung cancer in 2024, where we are, whether there is a need for adjuvant treatment after post-surgery, what the data says, what are the guidelines says, which drug, TKI, immunotherapy, checkpoint inhibitors, why, and what are the evidence I would like to discuss. So lung cancer, if you see the mortality point of view, 1.8 million death reported annually as per the data says, and 80% of the lung cancer patients, as Dr. Jyotika Jain mentioned about that, non-small cell lung cancer, and approximately, you can say, 30% of the patients are only in the early stage, as physician diagnose this disease in early stage and referring to the oncologist. But just see the broader picture of 5-year global overall survival in a post-surgery patient. If stage 1B, my word is very specific, stage 1B, the 5-year survival is 65 to 75%. And this decreases if there is a stage 2, 50 to 70%, means 5% drop in 5-year survival, even stage 1B to stage 2. Once there is a stage 3, again there is a drop in the tune of 22 to 25%, and the 5-year survival is only 30 to 45%. And I always remember the talk of Dr. Jyotika Jain, that she mentioned about that physician can diagnose this disease in early stage, then we can talk about a 5-year survival, which is like stage 1B, post-surgery and with the adjuvant treatment. Next slide, please. So this is very important. We never thought in early stage lung cancer that we should go for a NGS or specifically 3 targets, the EGFR mutation, ALK or PDL1. But if you see this paper, they mention about that the expert consensus recommended basically for a biomarker, even in an early stage, non-metastatic disease, post-surgery, role of adjuvant, basically treatment in the form of a TKI, immunotherapy like PDL1 or ALK targeted therapy. Next slide, please. So current testing is basically on stage 1 to stage 3. And the important thing which I want to discuss with you, that EGFR mutation prevalence was 51% with deletion 19, the most common, and this you can see very clearly. 50.5 means you can say 51% patients are deletion 19 positive, while L858R means exon 20, 36%, and the mutation, which is one of the important resistance reported with first generation and second generation, are T790, 3.3, and rest of the things are less than 2% or 3%. Next slide, please. Next slide, please. So current testing is very, very important. And just see, more than 2/3 of the patient, means in the tune of 73% or 74% patients are surgically resectable. Stage 2 and 3, only 47% patient received adjuvant systemic chemotherapy. The thing which I am highlighting you is multidisciplinary approach. If you see the treatment pattern, the overall, there are 3 ways: the surgical resection, adjuvant radiotherapy or chemotherapy, surgical resection plus radiotherapy, surgical resection plus chemotherapy, or only surgical resection. This is basically presented by colors. If you see the overall, the surgical resection plus RT plus chemotherapy is only in 4.3% overall. But if you see the combination of surgery plus chemotherapy in 22% patient, and surgery is only 73% patient, you can say up to 74% of the patient you can go for overall surgery if you pick up the disease in early stage. And if you see the stage 1A, my words are very specific that 96% or more than that patients are forward or subjected to the surgery followed by the adjuvant treatment. But once the stage 3B, surgery drop from 96 to 28%, or the chemotherapy increases from 3.4% to 42%, and the combination 28%. This means if you pick up the disease in early stage, surgery is the important aspect in lung cancer. Once the disease increases, chemoradiotherapy or chemotherapy play important role. Next slide, please. So once patient has a resectable disease, despite of surgery, as Dr. Jyotika Jain mentioned very clearly, that 50% to 60% patient has a recurrence of disease, whether this is a local disease recurrence or a dissemination of disease to visceral organ, bone mats, or a brain mats. Given that over half of the patient recur after curative intent surgery, this means we need an unmet need for adjuvant treatment in clinical practice. What are the data says in 2024? I would like to discuss in brief. Next slide, please. So this is the adjuvant chemotherapy after surgery for stage 1B to stage 3A, and the 5-year survival. You can say disease-free survival was 5% after 5 years, and the graph you can say initially look observation versus chemotherapy overlapping, but due course of a time was separated with p-value 0.017. While the disease-free survival again in the beginning was overlapping, but the curve was separated and the p-value is 0.002%. Next slide, please. So TKI, the adjuvant EGFR basically mutation, and the setting where we have used the TKI like first generation, second generation, and comparison with the placebo versus the chemotherapy. So these are the 5 trials. In brief, I am discussing SELECT trial, stage 1 and stage 3, EGFR mutation, comparing erlotinib after adjuvant chemotherapy plus minus radiotherapy. 2-year disease-free survival is 88% versus 76% historical control. Just see the adjuvant CTONGC 1004. Again, the stage is same, but gefitinib versus adjuvant chemotherapy, and there is a significant disease-free survival improvement, 28.7 months versus 18 months. No significant overall survival improvement seen, 75 versus 62%, and hazard ratio is 0.9%. Another trial, RADIANT trial, where erlotinib versus placebo. While in SELECT we have an erlotinib after adjuvant chemotherapy, here we have placebo after adjuvant chemotherapy, and clinical meaningful disease-free survival improvement in EGFR subgroup was 46.4 versus 28.5. While in event trials, once erlotinib comparing the adjuvant chemotherapy, there is a significant disease-free survival improvement, 42.4 versus 21 months. In a BR19, you can say comparison between gefitinib versus placebo after adjuvant, but there was no disease-free survival and overall survival benefit seen. This is in brief. I am discussing about the first generation TKI, once adjuvant chemotherapy or adjuvant comparison with the TKI. Next slide, please. So current evidence of EGFR TKI from randomized trial, adjuvant setting improved disease-free survival, but not overall survival benefit seen in this group, and hazard ratio is 0.64%. 48% reduction in the risk of disease recurrence. Reduction in the risk of disease recurrence differ by timing and sequencing of adjuvant TKI. Next slide, please. So why have these data not resulted in a change to clinical practice? Because if you see gefitinib, we are using for last 2 decades, but there is no adjuvant treatment advised by the randomized trial. So what are the reasons? Just see, trials to date have been limited by design, size, and other factors. Number 1. Number 2, overall survival benefit demonstrate to date. Third thing is unclear if adjuvant EGFR TKI therapy resulted in cure or delayed recurrence. And fourth reason was no definitive evidence on appropriate sequence, drug, or duration of treatment. Next slide, please. So this is the ADAURA trial, which Dr. Jyotika Jain clearly mentioned about that. A game changer in the sense of adjuvant setting if EGFR mutation is positive and patient has an early stage disease post-surgery. So I'm just discussing about the schema of this trial. The important aspect which I'm discussing with you, you can easily dissect the stage 1B to stage 3A. The important thing is in this trial, the inclusion criteria throughout the globe was more than 18 years or equal to that. But in Japan and Taiwan, the age group was more than 20 or equal to 20 years of age. The maximum interval between surgery and randomization was 10 weeks without adjuvant chemotherapy. This is very specific. 26 weeks with the adjuvant chemotherapy, randomized into 1:1 ratio, ositinib 80 milligrams and placebo. And this duration of trial was 3 years. And you will surprise that adjuvant treatment duration is again 3 years as per the NCCN guidelines. If the EGFR deletion 19 positive and you are subjecting the patient for osimertinib. Treatment continue till disease recurrence, treatment completion or discontinuation criteria met, and follow up as per the trial. And like all routine trials, we should see the progression-free survival, overall survival, disease-free control rate, safety, quality of life, and side effects. Next slide, please. So ADAURA trial, if you see, significantly improved disease-free survival, primary as well as overall population. And you can see that the graph since beginning is separated very wide. And median disease-free survival is 21.9 months in placebo. And you can see in third generation TKI osimertinib, 65.8 months. While overall population, you can see 28.1 in placebo versus 65.8. And this clearly shows that this drug is very, very effective in adjuvant setting because there is a very much separation of graphs since beginning. Next, please. Next slide, please. So adjuvant osimertinib has significantly improved CNS disease-free survival because this third generation TKI crosses the blood-brain barrier and effective even in brain mets. So CNS mets are a poor prognostic factor among patients with non-small cell lung cancer, and clinically, if you're not treating, the survival is less than 1 month. If you are treating with radiotherapy, then 6 to 9 months. But adding of the osimertinib, my few patients are surviving more than 2 to 3 years. The improved CNS efficacy was osimertinib treatment. You can see that greater penetration of the blood-brain barrier, and that's why this drug is effective even in brain mets. Higher exposure in the brain compared with the other TKI like first generation and second generation TKI. And adjuvant osimertinib demonstrates CNS disease-free survival benefit if you compare with the placebo, and the graph is clearly showing the advantage of this disease in brain mets patient. Next slide, please. So safety point of view, I would like to say that majority of TKIs are tolerable, except few patients are having a diarrhea, rashes. Otherwise, managed by most of the oncologists without any problem. There is no need for dose modification until less proved otherwise. This osimertinib again is a very safe drug as a TKI. I have not faced any major problem with any patient. And safety point of view, I would like to say safer than the chemotherapy. Next slide, please. So key takeaway points which I want to discuss with the randomized trial and 2024 guidelines. In order to improve survival, we need to put more effort to identify lung cancer early. As Dr. Jyotika Jain mentioned about that, if the physician can pick up the disease in early stage, then we can talk about the curative intent treatment with multidisciplinary approach. Never miss an opportunity to test for actionable mutation, particularly by the NGS or the PD-L1. If NGS is not possible, then you can go for 3 targets first: EGFR mutation, ALK, and PD-L1. These are the 3 category 1 recommendation from the NCCN guidelines. And you will surprise when the ALK is positive, then you can go for an adjuvant treatment of ALK-directed therapy for 2 years. If checkpoint inhibitors, then tumor should be more than 4 centimeters, no positive disease, and this should be for 12 cycle to 13 cycle. Atezolizumab jobs are basically different: 2 weekly, 3 weekly, 4 weekly, 840 milligram, 1200 milligram, and 1650 milligrams. Basically 2 weekly, 3 weekly, and 4 weekly for 2 years period. Pembrolizumab again for 1 year period, but you can go for a maximum 35 cycle in a metastatic disease. But for adjuvant setting, OP data is again for 13 cycle. Now this is applying early lung cancer, also especially for EGFR mutation. You can switch on the osimertinib as per the ADAURA trial for 3 years as an adjuvant setting as per the trial. Collaboration with the multidisciplinary team is a key to improve the survival. Next slide, please. So take-home message is very clear. We discussed a lot in last 2 hours. We have 2 experts' opinion in overall lung cancer. Patient may ask for treatment option for best survival possibility in 2024. We have a cytotoxic drug, we have a TKI, we have a checkpoint inhibitors. As per the NGS report, you can select your target and put in the adjuvant setting. Be ready to discuss other offer them as per the best available data, because the science is moving so fast. As Dr. Jyotika Jain mentioned about CAR cell therapy, I don't know about what will be in future, but presently we have a TKI as well as checkpoint inhibitors in adjuvant setting. Those who are having a post-surgery high risk stage 1B to stage 3A. ADAURA data give a probability of patient to remain cancer-free along with the survival benefit. Being cancer-free is a goal of patient as well as his and her treating physician. This is my concept. Next slide, please. Thank you very much for your kind attention me. If there is any question, you can ask me, or you can ask my experts, those who have given the experts' opinion in their and deliberation in their talk. If there is no question, I hand over the mic to the organizer. I personally say thank to all my experts, my delegates, those who have joined the scientific program and listening me patiently.
Thank you very much, sir. Thank you, sir. Thank you, AstraZeneca.
So thank you.
Hand over to mic to the hello. Hand over to mic to the Samir Vyas for vote of thanks.
Thank you very much, sir. I would like to thank all our speakers for their outstanding contribution and the active participation of the audience. So
thank you and good night to all of you.
Thank you so much.
Thank you. Thank you, Samar. Thank you so much. Thank you, everyone, for joining.